Hey guys, welcome back to my channel. This video is about bilateral sagittal split osteotomy. This orthognathic surgery is used either to advance mandible or retrude mandible and even used to correct the jaw asymmetries. So we give here three types of cut: medial, sagittal and vertical, and the sequence of these cuts depends on the surgeon's preference. Then unification of these segments is brought about by plates or screws. Let us understand this technique quickly. So, vertical cuts or cut on outer cortex is given. We do not have to go into the cancellous bone area or medullary area because there we have neurovascular bundle and we have to preserve the inferior alveolar nerve. So, we give this cut in the first molar area or between first and second molar, and then accordingly mandible is either taken forward or retruded depending on the situation or case. Then sagittal cut is given that separates the inner and outer cortex. You see this red line here for sagittal cut, that is from buccal to lingual cortex. And then after that, the third cut or medial cut is given, that is just posterior to the mandible foramen or above the lingula. In the earlier technique, this technique that was first given by Wegesser. So in that technique, they used to cut till the posterior region of the jaw. But here, after this technique has been modified, we give this medial cut just above the lingula and behind the foramen. And then this bone separates and a fracture line develops. This technique is very simple and you must draw all these diagrams in exams to get good scores. Illustrations or diagrams are really important for oral surgery, just like anatomy. You need not write a huge essay type answer, but you should draw proper diagrams, and this will take time, so do not waste your time on drawing good diagrams. Okay, you can just draw just so that they are understandable. So this is how you should attempt this LAQ. Okay, this procedure is carried out under general anesthesia and local infiltration is also given. We retract tissues buccally before the incision. Then incision is given on the anterior aspect of ramus of mandible. It is continued till mid-ramus, over the external oblique ridge and till first molar tooth. Incision is then extended down into the buccal vestibule. Then mucoperiosteal flap elevation is done. Then level of lingula and mandibular foramen are ascertained so that cut is given properly. Then cut should be given above lingula and extend just posterior to the mandibular foramen. Like I said, this cut sequence of these cuts is given by depends on surgeon's preference. So there's this medial cut or medial osteotomy, sagittal osteotomy and vertical osteotomy. So we'll go as per the textbook. So medial cut is given. This cut is taken anteriorly to the anterior border of ramus and continued along the external oblique ridge till the second molar region. Then a vertical cut is given between the first and second molar, not deep, and it should be enough to reach cancellous bone. We'll feel that ditch or dip as we reach the cancellous bone. Then this spatula osteotome is malleted and Smith spreader is used to separate these segments, but you have to be extremely cautious with the Smith spreader. And during the splitting, neurovascular bundle should be visualized and care taken to maintain it to the distal segment or the segment which has teeth, the segment with dentulous area. Then this procedure is repeated on the other side, as this is a bilateral surgery. Medial pterygoid muscle, they are separated from the distal segments, and condyle is placed in its anatomic position in the glenoid fossa. This is very important, should be done before fixation to prevent condylar sag. Then fixation is carried out using LAQ screws or bicortical screws, either 2 or 3 mini plates, or so rigid internal fixation is done, or lower border wiring or upper border wiring, or even circumramus body wiring is done to carry out the fixation. And take note of these points that muscles are removed to prevent the relapse in surgery. And it is said that third molar extraction should be done 6 months or 8 months prior to surgery, but this is still controversial because some surgeons prefer to remove third molar at the time of surgery. About wound closure, wounds are well irrigated with saline and edema is expected, which results in 2 weeks, and diminished sensation of lips may be experienced by some patients due to injury to the inferior alveolar nerve. More than 2/3 of the patients experience some sensory deficit even after 1 year. And there's a list of complications like injury to the inferior alveolar neurovascular bundle, and if mistakenly this nerve is transected, contents should be microanastomosed. There can be malpositioning of condylar segment or bad splits and excessive bleeding. Bleeding can occur from the inferior neurovascular bundle, facial vessels, medullary bed, and rarely from retromandibular vein. And except for the facial vessels, bleeding can be controlled by local measures, but if it is facial vessel, they have to be identified and ligated. That was all about BSSO. I hope you like this video. Thank you for watching.